Oh, there we go. Excellent.
Thanks, Kellen. Okay, so I'm going to share my screen. So let me just prepare my
And there you go. Looks.
Give me just a second. Hold on.
Yeah.
Sorry. There's a. Sorry, everyone.
No worries. Just take your time, Rebecca.
Okay, so hopefully you all can see my screen here. Now,
Yep,
this presentation, great, okay. This presentation is on chronic pain. Is this part of Clinical Collaborative's series, Aging Gracefully. I titled it Thoughts and Solutions on Chronic Pain, in part because we are going to be talking about a lot of things here, but hopefully when you finish this presentation, when I finish this presentation, when you finish listening, you will not only have a better understanding of pain and chronic pain, but also have some ideas of ways that people can be managed with it. So first, like I said, we're going to define pain. We're also going to discuss how to manage pain, and you're also going to understand some physiology about pain. Now, the first thing here I want to talk about is, number one, defining pain. Pain is an experience. Pain is subjective. And we're also going to talk about chronic versus acute pain and how to differentiate the two. So, you know, there are specific receptors in the body. They're nerve endings that present pain to your brain. And these nerve endings exist throughout your entire body, and they will take any perception of pain, move it up through the nervous system, up the spinal cord, where it then goes to the brain and is interpreted by the brain. Now, the reason that I'm kind of breaking this down in a simplistic way is because what I want you to know is that when pain goes up to the brain, it can be modified in certain ways by the brain, depending on past experiences, depending on your physiology of your brain and exactly how your brain interprets pain. So that sort of kind of like lays the groundwork for the subjective part of really why pain can be so subjective and why it's different for everybody. It's because it really is, it has so much to do with the way that the brain processes it. Now, the process for going through this nervous system up the spinal cord is the same for everyone. But it's really how it's modified in the brain that's different. So, you know, I think that a big thing here is to know that then after the brain modifies it, it shoots it back down the nervous system, down the spinal cord, into the peripheral nerves, where then however it was interpreted by the brain, it's then released to those nerves, and that's what you're experiencing. Like when you burn your hand, for example, that was, I think, what this picture was trying to show. So I think another thing to know is that pain can be physical, and it can also be related to emotion, and that's why I brought up it being processed in the brain, because so much of the processing happens in the brain. So it actually is connected to the same parts of the brain where emotions are processed too. So the two are actually very connected. So to say pain is just physical or just emotional, it's not correct. It's actually both. And ideally, pain is really just responding to some physical thing that has happened, but it's not always the case. Then, you know, there's the idea of pain being subjective then is very real, because there's no technology that exists, no labs, no imaging, no sort of thermometer for pain. It is really just based on the perception of the person that is experiencing the pain. And then on top of that, it is based on the person's expression of how they're perceiving that pain. So there's a lot of nuances in pain that we are not going to sort of be able to define in a really in a way that encompasses everybody's experience. So, you know, pain is typically associated with actual physical damage to the body, but it's not always. And when you cannot find a physicality or some reason for pain that's very physical, it can be really upsetting for people. And to not know what the source of pain is actually can make pain even worse, and it can make the stress response higher, which can make pain worse. So that's kind of laying the groundwork for how chronic pain becomes a thing sometimes. But just moving back to defining pain and pain in general, I want to just talk quickly about chronic pain versus acute pain and like the medical sort of like definitions that differentiate the two. So pain that is acute is meaning it lasts less than 6 months. And it is also supposed to be something that is a useful sign that something is wrong in your body. And for acute pain, often rest is recommended. So, and it's expected to go away within that 6-month time period. But once you move on to chronic pain, then it lasts greater than 6 months, and it becomes an illness itself versus just a symptom of an illness or some occurrence. It's no longer a useful warning sign that something is wrong, and actually resting too much can be a bad thing in the sense, or in the setting of chronic pain. So now moving on to, you know, back to the connection, the emotional connection to pain. You know, there is a biopsychosocial model that connects the two. The chronic pain cycle demonstrates that this chronic pain cycle that I'm about to show you demonstrates the interplay between chronic pain and all the domains of your life: physical, emotional health, your social well-being, and then how that affects family, work, everything. So I'm just going to start at the top of the picture here, where you have this pain that occurs. When somebody is experiencing chronic pain, it starts with an initial pain that becomes persistent. And then how this cycle goes on is that chronic pain can lead to people becoming less active. So then you move on to the next picture of this guy lying on the couch. And the reasons for people becoming less active are different for a lot of different people. Sometimes it's due to the fact that literally walking can be painful. It can be so painful that people do it less. Sometimes it's because they're afraid, people that are experiencing pain are afraid of making pain worse. It's not that it necessarily makes the pain worse to walk, but they're afraid of it making it worse. So then also, like, with that fear comes like things like muscle guarding and restricting your range of motion. Like in that picture, the first picture, this person's arm hurts. You know, you might find that somebody stops themselves from, you know, stops themselves from, okay. You might find that somebody like will stop themselves from like reaching up at a bookstore to get a book. This is a really small example, but you see that, like, if there is that over and over and over again, it can lead to limiting range of motion. And actually that alone can make pain worse by, you know, atrophying the muscles, and, you know, you're doing a lot of actual damage by not using those things in the setting of chronic pain. Now, you might, if you actually have a shoulder injury, somebody might tell you limiting range of motion for a period of time is very important, but this is more like on the chronic pain setting. Okay, so when you become less active, then your body starts to lose fitness. It starts to lose muscle mass, that atrophy word that I was talking about. The joints become stiffer. All of these things can actually lead you into the next cycle, which is having just lack of energy and being tired all the time. Because if you think of like an athlete during spring training, how they feel physically at the beginning of spring training is actually like a lot more fatigued when they're first getting back into the motion of, playing their game. And as a result, these athletes have like less stamina and they feel more tired. They have less energy, and they experience lower energy at the beginning of the season. And that would be a same example for somebody experiencing chronic pain and using their body less. So then that moves into the mood and emotions that associated with these things. When you feel tired or fatigued, then, it can really be something that stops you from doing a lot more things. It can cause you stress. It can cause you anxiety. You can become, frustrated and angry about not being able to do the things that you once were able to do. It's natural to have negative emotions, such as like irritability or stress, when you feel like you're fatigued, and when especially that's related to pain, because the simple feeling of pain is, as we all know, not comfortable. So there are negative thoughts, like I said, accompanying these things. And then, that will start to become cyclical. And then you find that in this model of pain, you find that people are, become more restricted from like the activities that they physically do, but also emotionally the things that they participate in. People start to avoid, like going to birthday parties and doing activities with their friends, and that a lot of is associated with the physical limitations, but also like the mood and the feelings that are associated with all of these things, and that leads to depression. And then you find that these people are doing less and less, and their depression is, associated with mood swings. And then you can, all of this stuff leads to needing time off work, being concerned about money because you need time off work. And all of that is all being processed in the same area of your brain as the pain is. So now what we want to do is talk about breaking that cycle. And there's a lot to be said about breaking that cycle. And there's a lot of, physiology to discuss about that. So I think I want to take a minute here to see if there are any questions in the chat. So I'll ask Ashley, if you don't mind, do you see any questions in the chat that we can address?
Hi, Becca. No questions yet. I think Kellen has been kind of fielding questions about whether or not the slides will be available, and then also just making sure folks know that you can post your questions in the Q&A section or in the chat. If you want to make sure that we go through them in like a really thorough way, the Q&A probably is best. That way Callan and I have one place to look, but if you have something, feel free to put it in the chat. But no, Becca, nothing as of right now, but you're doing great.
Thanks, Ashley. All right, so now we're going to move on to more of the physiology of pain and the differences in the types of pain. So there was acute versus chronic, but then there's also in ways to differentiate types of pain. This is important in that there are different nerve endings in different parts of the body. So there's somatic pain, visceral pain, and neuropathic pain. And these are all qualified in different categories because of the location of the nerves in each of these different types of pain. And because of the location of the nerves are different, they're actually processed by the body differently. And so they feel very different from each other. And because they feel different from each other, then we tackle the pain in different ways too. So the different locations of these nerves and the reflexes where these nerves exist is for first, somatic pain is mostly in skeletal and muscle sort of those nerves innervate in the skeletal system and the muscles in the body, where visceral nerves are more like soft tissue organs, the deep inside sort of things that are happening like deep inside. So you can imagine that like appendicitis feels different than like a cut on your arm. And really, like if you're asking patients about like one of the things that we do in medicine is we ask patients to describe the pain, because we won't just say like on a scale of 1 to 10, how bad is your pain? We'll ask you to qualify the pain. Can you tell me, is it dull? Is it achy? Is it burny? Is it sharp? We don't say burning. So the reason is because if you qualify and describe these pains differently, then it'll help us manage the pain with different medications. So like I talked about the somatic nerves, the visceral nerves, and then the neuropathic pain is related to like central nervous system and like peripheral nervous system. It's like things that are especially related to like nerve damage. And these are all like usually peripheral nerves, which is like nerves that are coming off of like basically any nerves in your body outside of like your spinal cord and your brain. And what happens is when those are damaged, they can fire inappropriately. And that is like, once there's a nerve damage, then the firing happens like inappropriately and too much. And that can be a source of pain too. So, and I'm going to describe each of these things now. The somatic pain, when somebody says aching or throbbing and like deep, those are more somatic. Those are related to like a more somatic pain. So the best thing to do for this is like Tylenol and ibuprofen. And, these are things like, trauma, like a cut on the skin, or muscle pain is a big somatic cause for pain. We have like, for example, when I work in also like a surgical specialty as well. So when we ask people about their pain after surgery, actually one of the biggest problems that people have right after surgery is the muscle soreness. Like they describe it as sore, related to like when you have to like cut into somebody's muscle. So if you have muscle damage, like in the surgical setting, it's like being cut into the muscle. That pain is actually super similar to like if you work out too much and I keep pointing to my belly because like I'm talking like abdominal surgery, stuff like that. You cut into that muscle, and then that feels the same as like if you did 1,000 sit-ups and you just like totally overdid it. That soreness and like the aching is very similar. It's because it's all related to that somatic pain, that muscle pain. That is also to say that like bone fractures or like a bone, breaking a bone is also the nerves are similar. So no, it doesn't feel the exact same, but the description of the way that these things are is very similar. And and I also just want to talk about like ibuprofen and Tylenol. The reason that these are the best medications for this type of pain is because there's this kind of like some cytokines are proteins that are released when there is something like a fracture of a bone or swelling in the muscles, stuff like this. Like these cytokines, these proteins are released to a place where the nerves identify that there's been damage happening, and then this cascades of a series of events that then draw like white blood cells into that area of the body, lymphocytes and like macrophages. These are all sort of like back to like biology 101. All of these things can come flooding into that area. They cause swelling, they cause vasodilation, so that all of these different proteins and cells can come into the body and start sort of like helping restore whatever damage there was. So like the swelling, the redness, all of these things that you see with like a cut on your arm or something like that, there's a reason for it. But also, that alone causes a lot of pain. So if you give Tylenol, if you give ibuprofen, these things actually can stop the release of these cytokines and this whole series of events that can cause a lot of like swelling and pain. So Tylenol and ibuprofen are great for pain related to like this swelling and somatic injury. So I'm going to stop there very quickly just to see if there are any questions.
Hey, Becca, you've got two. Okay, so one is just kind of an ask that the screen view could be focused on the PowerPoint or make the PowerPoint larger to see. I don't know if someone, it seems like you're Zoom, so whoever is asking that, you might check your view options. If you make the slide in side-by-side speaker, it'll make Becca smaller and the slide larger. So hopefully that helps.
You can also go up to the top and choose full screen. You won't see Becca when you do that, but you'll see a larger version of the slide in front of you.
So that's thing one. Then we have a raised hand here. So Judith Weitzner has their hand up. But since everyone is muted, maybe Judith, you could put your question in either the chat or the Q&A. So we'll give Judith a couple minutes to put that in there. But we have a question from David. Says, I have neuropathy in my legs and feet. I experience numbness all the time and occasionally cold, and I've had a few falls because of this. So want to give you an opportunity to respond to that. And then we have another question, but maybe you take David's and then we'll wait to hear from Judith. And then we have Adam as well.
Okay, great. So the questions and comments are really helpful in kind of like, you know, delivering this information that in a meaningful way for all of you guys. So I encourage them. Thank you so much for the comment, David. We are going to talk about neuropathy and sort of managing neuropathy. But I appreciate you sharing that, because this is a really big thing that a big problem that people are living with, and it's a difficult pain to manage. There, as you see in the slide that's up, there are ways to manage it, but it doesn't come without side effects. And also you are bringing up a very important thing here, which is neuropathy can be really dangerous for people because it can lead to falls. If you have numbness, and you probably are, we're describing many people in the United States and all over the world that are experiencing nerve-related pain that causes numbness, or, you know, the other pain descriptors that we'll go through. But the numbness is a big one, because that numbness is there. It makes it difficult to feel, you know, really like if you're stepping over a carpet or something. And David, if you were able to unmute yourself in this setting, I'm sure you could really describe this super well. But that if you can't feel that, it puts you at such a high risk of falls. So it's dangerous, and it brings up an important point, especially for those that are frail. Those falls can lead to, you know, all kinds of other problems, especially for older folks. So reducing the risk of falls and managing neuropathic pain is very important to reduce like the risk of any other further problems.
Beautiful. Okay, then let's see a couple more things. So I believe Adam was next, and question is, with chronic pain, taking Tylenol and ibuprofen can create other problems. So what do you suggest for those with chronic pain that does not rely upon medications? And then we have also another one after this.
We're going to talk about other ways to manage pain outside of medications. So that's going to be in a couple slides. Actually, it's the next slide. But I will say that it depends on the type of pain that you're experiencing, where, I mean, there are a slew of other things that you can do. Most commonly, we see arthritis be the reason that people take Tylenol and ibuprofen. And that's because that it's classically, like the chronic swelling that's related to that type of pain. The chronic swelling can be reduced with Tylenol and ibuprofen. And I agree that there are problems with those medications. And I have that in a few slides too. But I'll just kind of quickly tell you, Tylenol, not safe for people with liver disease to take. Ibuprofen, not safe for people that have, history of like a GI bleed or like ulcers. Also, for people that have heart disease and have had history of like heart attacks and things like that. There's a warning on like an ibuprofen bottle saying that this is something that you have to talk to your doctor about. And so my suggestion is, really like know exactly what the risks and benefits are with that by having a conversation with your doctor if you are somebody with heart disease. And that needs to take ibuprofen, because it's not something that's completely contraindicated, meaning like you can't do them at the same time, but it's really about evaluating the risks for that specific person. And then in terms of like, if you're somebody with ulcers or GI issues that can be exacerbated with ibuprofen, like not taking it at the same time as like aspirin and ibuprofen can put you at risk for those bleeds and like the ulcers that we're talking about. Taking ibuprofen with a full belly, making sure you get like a full glass of water and a breakfast with it before you take it. Those are also important things to note.
Thanks, Becca. Okay, so there's a couple more things. Most of these are, okay, we have two more questions. So Rachel says, hello, can people suffer from more than one type of pain at the same time, depending on what injury or pathology is that they're suffering from?
Thanks for saying that, Rachel. And the answer is astounding yes. Somebody can have chronic arthritis and also have neuropathic pain related to diabetes. Diabetic neuropathy is the number one cause for that neuropathic pain that we're going to talk about in a minute. And those two things can exist at the same time. And commonly you'll see people that have to take gabapentin, which is the medicine for the neuropathic pain that we'll talk about in a minute. And you'll see ibuprofen or Tylenol on their list of their medication list. So they are very commonly seen together.
Another one is mostly problem solving around the Zoom ratio. So Catlin, maybe I'll let you handle that one. But the next question for you, Becca, is from Beulah. I'm hoping I'm saying that right. The question is, I have pain on the right side back and tingling down my left leg. I have pain that feels like cold. I use a heating pad and it does not relieve the pain or coldness.
Okay, so the pain down the leg is classic neuropathic pain, radicular pain, that like there's a nerve that goes down your back, down your legs. And this is a very, very common issue that people have. And it's a really hard thing to manage. And gabapentin and those medications that we're going to talk about for neuropathic pain is really the best mainstay way of managing that type of pain, the pain that shoots down the leg. It is, I could try to find some numbers about how common that is, but it's a super common experience. And typically, for like in terms of how a doctor would manage that, it has to be like 6 months or greater for somebody to then do sort of like any sort of imaging, like a CT scan or an MRI, to evaluate to see if it's anything further than just like that nerve that goes down your leg. Because it is possible that it's something else, right? Like what you say in medicine is like, don't go looking for zebras. And that is like, you have to treat it like zebras in a herd of horses. That's the saying. So like, you have to treat it like it's an expected, it's one of the most common findings for neuropathic pain. And so you have to treat it that way. But if it's been greater than 6 months and the medicines aren't helping, then a doctor might consider doing, further workup to make sure it's not something else.
Okay.
And as for the question regarding the view options, there is an option at the top of each of your screens, you'll see view, which allows you to choose standard, side-by-side speaker, side-by-side gallery, etc. But above that, there's something called view options. And if you click on that and then just look below that, there'll be a drop-down screen that says zoom ratio fit to window. You can fit it to window, and then there's another screen, a square that pops up that says 50%, 100% original size, and so on, going up, so that you can adjust it to fit your screen. You might want to give that a whirl if you need to adjust it. But as I said, we will be sending out the slides to everybody as well. So as Rebecca goes through these, just know that those will also be coming your way.
Thank you, Caitlin and Ashley. I will say that I did try and like make it bigger on my side, and I wasn't successful. So,
all right, Becca, I think that's all we have for the open questions. So yeah, you're good to go.
Okay, great. Thank you. So now I'm going to just talk about visceral pain, and we've gotten the idea, right, that we've gotten the sense of the different types of pain, but this is all really important as you're gathering in how to manage it and what to do about it. So types of visceral pain that you might see are like digestive problems, like constipation can cause a lot of visceral pain for people. And that's also something I think about, all of the ways that you manage pain. And opioids, I'm getting to opioids. We're going to talk a lot about opioids, but opioids cause side effects. And one of the side effects is constipation. And so you can see how you can actually like make the cycle worse if you overmanage somebody's pain with certain medications like opioids. And then like somebody mentioned about like the side effects of like ibuprofen and Tylenol. So all of the different ways that you can manage pain without medicine is going to be important, and we're going to get to it in a minute. But so that's why I wanted to bring that up. Okay, so visceral pain, like things that are like deep inside, like your internal organs, like other things are like appendicitis, or like specific damage, like liver damage, things like that can, or like pancreatitis, all of these internal issues that are then described as like, instead of like achy and throbby, it's like dull and more like vague. Like if somebody's experiencing some of those things, they cannot point to a specific spot where it hurts. They'll tell you like, oh, it's like a general pain in this area. That's more common. And so opioids are better for this type of pain more commonly. But you'll also see that people will give like steroids for this kind of pain too. Now, I'm not going to get into steroids actually, because that's a really big topic that I could do a whole talk on that alone, about all the risks related to like chronic steroid use. But things like getting like a steroid injection might also like it can also help with that sort of, they can help with somatic pain and visceral pain, but that's like a lesser risky version of like steroid use. And now I'm going to go on to neuropathic pain. Now, this one is described as commonly like burning, tingling, numbness, and then like the shooting electrical sort of pain that somebody described, like at the back of like going from their back down their leg. Those are all classic like neuropathic nerve type pains. And like I said, when there's nerve damage, it's the nerve damage alone can be a cause of some amount of pain, but it's actually like the ectopic firing of these nerves that causes a lot of like exacerbated, like sort of like pain that becomes chronic. And the ways that you can end up with chronic nerve damage is like diabetes. So that's why diabetic neuropathy is very common. And the ways that those things are damaged is because and this goes for, it's like a lot of different, like high blood pressure, diabetes, these things can cause low like blood flow to the very, very tiny little capillaries and like the tips of your fingers and your toes. And then if there's not enough blood flow, then there can be a certain amount of like damage to the nerves. If it's not getting enough blood flow, there's nerve damage. And then that's how you end up with neuropathy. And then there's also like cancer related neuropathy. This is really common in people that are getting chemotherapy, because if you probably have seen people that are getting chemotherapy end up having to take gabapentin, and like the way that we will decide when to peel back somebody's chemotherapy that's presumably life-saving chemotherapy, like maybe we'll decrease the amount that they're getting once somebody describes this neuropathy pain that they're having as some, like when they cannot button a shirt. So that's a really common way that we're measuring it. Okay, so your neuropathy is bad. Let's increase your gabapentin. And also, like, can you please like button a shirt and show us that you can do it? Because once there's like a certain amount of damage done, like this is actually something that's really, it's not reversible. So you can manage it with these certain medications that cease that ectopic firing of those nerves, but it's not something that you can reverse. And so other things that can happen that you can see it with is like multiple sclerosis, Parkinson's, those like nerve related diseases that are not just like, things that cause like the reduced blood flow, like the diabetes and stuff. So medicines that affect the central nervous system, peripheral nervous system, that can stop that ectopic firing are things like gabapentin. That's like the number one. Neurontin is how it's also written on here. Lyrica is really common. You'll probably see that on people's med lists. And then interestingly, also like antidepressants, Cymbalta and Effexor can help with this type of pain too. Then also like this, there is some data to support this, but lidocaine patches, you can get them like at CVS. Not just like the hot and cold packs that you see at CVS where it's like, it starts like activating a hot, the hot and the cold, but it's actually like medicated like lidocaine and an anesthetic like that goes on the skin that can help with that type of pain too. But really, the bulk of it is like the anticonvulsants, the things that suppress the central nervous system, and that ectopic firing is like gabapentin. So now let's move on to options for treating chronic pain. So we've already talked about medications quite a bit, but we're going to talk about them more. And then we're also going to talk about physical therapy, also some medical procedures that can help, and like things like nerve blocks. And there's also complementary therapies and lifestyle changes. So the first thing is, some of the most common reasons for chronic pain are back and neck injuries, like also that lead to arthritis. Also fibromyalgia is another common reason to have this. Commonly, it's more like a nerve related pain that's more common in women than it is men. And then also, there is like the diabetic neuropathy. That's also another common neuropathic type pain that we see. So Tylenol, like I explained, the way that Tylenol and ibuprofen both work in reducing that, like the cascade of events that causes swelling. They call both of these anti-inflammatories because all that inflammation that causes the pain, Tylenol and ibuprofen can help stop. So I'm a big proponent of these medications. They're, there is reasons that you can't take them, like I described in the last slide, but I'll go into a little more detail. Tylenol, like I said, it's completely processed through the liver. So if you have liver disease, it's not a good option for you. And then also, like if you are drinking alcohol with Tylenol, alcohol is also completely processed through the liver. So combining those two things is not safe. And then, so that like, you'll have to like decide like what type of medication is best for you, and your doctor would help you make that decision. But generally speaking, it's a really safe medication. And it's a reason that we give it to like kids a lot. Like acetaminophen is the other name for Tylenol. And you'll see that actually Tylenol is like one of like, you can get ibuprofen for kids too, but Tylenol is like given to like even younger kids at like an earlier age, because it's generally a really safe medicine. And then ibuprofen that is a medicine that is completely processed in the kidneys. So if you have kidney disease, this is not a good option for you, or you need to talk to your doctor before taking it. And also, like I talked about, like acid reflux, sort of like people that have ulcers, people with cardiac disease, those are people that need to talk to their doctor too before taking ibuprofen. But generally, again, they give it to young kids. I mean, in smaller doses, obviously, because kids are smaller and stuff, but NSAIDs and ibuprofen, Aleve, those are all sort of like in the same class of medicine, and they're all NSAIDs, and those are generally good options too. And Ashley, is there any questions about those things?
Mm-hmm.
Okay.
Yeah, so we've got two. One is a really great share from Gwendolyn, talking specifically about the interactions that medications can have and how treating pain can have perhaps unintended additional consequences. And then Joe from Open House has some other interactions to talk about. But Gwendolyn says, I wanted to share that I tried Cymbalta and had suicidal ideation as a result. And I know this because it quit when I discontinued the drug. I have fibromyalgia as well, but I was dealing with pain from knee replacement. My doctors were so helpful that this would be helpful.
Thank you for sharing that. That's an important thing that I didn't bring up. And you know, the list of possible adverse effects to all of these medications, really, I could go on and on. I'm hitting the big ones, but Cymbalta and antidepressants are, those are things that need to be watched closely when people are started on them new. And sure, it can be helpful with pain. But again, it's always balancing the risks and the benefits. If somebody starts to develop these suicidal ideations as a result of this medication, which is a known possible effect of this medication, which is really scary, then yeah, people need to be watched really closely. So that's a big one. And important thing that I appreciate you bringing up, because doctors watching for these things very closely is extremely important.
Yeah, great. And then Open House, one of the clinical collaborative members, is here, and Joe has highlighted that there's possibly a negative interaction between Tylenol and aspirin and lithium, and maybe Advil and lithium. Do you know anything about that?
I will say that I don't know a lot about a lot of like the antipsychotic medications, like that's like the class of medicine, like lithium. So I cannot say that I know a lot about the interactions between these things, but I do think what Joe's bringing up is a really important thing to talk about in general, which is just general interactions of medications. Like, that's a great example. And I know lithium is like an older drug and actually has interactions with a lot of different medicines. Another example of a medicine that has interactions with like almost everything is like if you see somebody on digoxin for their heart, that one has like the list of interactions for that one. Also, it goes on and on. And I know lithium is similar to that. I don't know lithium, the drug, very well though. But I think it's an important thing to bring up, especially if you are putting somebody on any sort of like, it's important to have a provider that really has the understanding of like antidepressants and these medicines that are actually really nuanced, and the antipsychotic class of medications it's a really nuanced class of medicines to take very seriously, and also to wrap in the entire person. So if somebody, it's not like somebody that needs this medicine doesn't experience pain. So knowing those interactions is really important. And I'm sorry, I don't have more information about that specific interaction.
Yeah, I think that covers most of what got brought up in the chat. And this is also kind of to speak to our collaborative members, right? This is also why our medication list is a large part of our initial assessments. Yeah, okay. So, and then everyone, I'm going to go back into the background, but you can see just how much your contributions really enrich the conversation. So feel free to put any questions or comments in the chat and Q&A, and we'll pause and make sure that we cover it.
Yeah, thanks for saying that, Ashley.
Mm-hmm.
Another thing I wanted to talk about was also like kidney disease with gabapentin. The bulk of medicines in general are your body's ability to metabolize these medicines. It really goes through like the kidneys or the liver. Those are your big ways of processing medicine. So if you have either kidney disease or liver disease, likely in some way, like one type of medicine is not going to work for you compared to like another. So gabapentin is also processed through the kidneys. So it's not to say that you can't take these medicines. Again, it's all just like, knowing like what your processing ability is of your kidneys, and then also just like reducing the amount of gabapentin or other medicine that you might need to take for like a neuropathic pain. I don't think that it's the same case for like SSRIs and other sort of like antidepressants that can help with this type of pain. I think that's a little bit different, but I keep talking about gabapentin specifically because I'm trying to just hit on like the big players here. And gabapentin is the most commonly prescribed medicine for neuropathic related pain. But this is not to say that it's not super nuanced in the different types and the different medicines that there are and how they are to be managed specifically for people with different diseases, and also that take specific medications, like the great point of bringing up lithium. Knowing those interactions is so key. Okay, so now moving on to physical therapy. So some types of pain also are great to be managed with physical therapy, and it can really help to like build up your body's muscles and like the ability to like stretch with like all of the tendons and the supportive sort of like ligaments and all of these things that help support these structures in your body. Because actually it can be that there can be weakness, like I talked about, that's causing some of this pain. Like for example, back pain in the United States is very, very common, as we all know. And physical therapy is a great option for back pain because there's a high number of people that actually have an improved pain related to like lower back pain specifically when they do physical therapy, because inherently actually some amount of it is muscle weakness and like all the tendons and the muscles that support the spine. If it's not super strong and able to support that structure, it can actually cause pain. So building up, it's not just about being stronger, right? Like it doesn't mean you just like go to the gym and you just like need to like just work on like getting on the treadmill. It's like being very specific about where you focus in the strengthening, because the very specific areas of strengthening can help with certain types of pain, especially back pain. And that's to say that we're going to talk about complementary therapies too in a minute, but like that I just want to like wrap it back into like the strength building that can help. Like yoga is actually something, because of all like the core work involved in yoga and like the stretching involved in yoga, some physical therapists will then recommend people with lower back pain to also participate in yoga after they've like gotten specific physical therapy exercises to strengthen the specific areas that are important for lower back pain. And like continuing that with something like yoga is something that you might see commonly. And then there's also like things that physical therapy can give you is like manual therapy is what they'll call it. And it's like kind of like massage therapy, because it's not just as simple as being stronger or being more flexible. It can actually be like a lot of like tightness that needs to be relieved, and massage therapy really works, and it works so well that actually physical therapists will even do it or suggest it. And I see, Ashley, maybe there's probably a question.
Yeah, we've got a couple here. mostly in speaking to the medication piece. So Donna just is making a comment, and I imagine Donna's not the only one, saying that I personally have not found any medication that helps with neuropathy. And then I don't know if this is perhaps related, but David is mentioning or asking, what exactly is a high dose of gabapentin? So specifically, David takes 300 milligrams at night. So those are the two that have come up right now.
Okay, thank you. I am sorry to Donna to hear that their pain is not, the neuropathy is not improved with any medication. It's a tough thing to treat. I think it's important to have a lot of different options being provided to you. So I hope that your provider has offered at least all the medicines in the slide that from a couple of slides ago, and the slides will be available. But at the very least, and then once it goes past that, I mean, I hope it's really important to also know that like one medicine is not going to be the cure all, but like medicine combined with some of these other things might be helpful. But neuropathy specifically is not, that one's, I mean, physical therapy is not going to be helpful, but there is like biofeedback, relaxation, meditation that can just, it doesn't help with the actual physiology of what's happening to you, but it can help with that processing in the brain, like we talked about at the beginning, and how your brain then sends the signal back out. So, it's a difficult thing to manage. So thanks for sharing that. And then in terms of common doses of gabapentin, 300 milligrams at night is a very common dose. 100 milligrams 3 times a day is also a common dose. So it kind of just like depends. But 300 milligrams is a common way to start, or 100 milligrams is a common way to start. And I've seen it as high as I mean, this is usually for like people that are getting like active chemotherapy, but this is like one of the highest doses I've seen is like 600 milligrams twice a day. I've seen 400 milligrams three times a day. So there is room to go higher, but there is a very big caveat with that medicine specifically, which is that fatigue is like the number one side effect that really affects people's life. So it is not to be taken lightly to just increase gabapentin or any of these central nervous system depressants, because fatigue is major. And then if you're combining that with opioids, and I haven't brought up opioids a lot yet because I have a whole slide on it. But if you combine that with opioids, then you have to also consider the fact that like opioids are super cause a lot of fatigue and central nervous system depression. So you combine those two things, and it is not safe to just be increasing kind of like willy-nilly. It's like something to be watching very safely or very closely.
All right, Becca, we've got kind of a queue here. So thank you everybody for piping up. Really we're opening many doors. So Dana has something in the chat. The side of my foot has a sharp pain occasionally, and the only thing that helps it is deep massage, and then it completely goes away. And so there's a question, I'm curious about why it comes and goes. And then there's 3 others after this, but we'll have you respond to Dana first.
Okay. Just the idea of recurrent pain is, I mean, it's so common. And in terms of like why it comes and goes, like there is something inherently happening in, I mean, it could be, and I don't know all the details of it, but it could be that you had an injury at one point and that has like caused like some chronic pain. Like I specifically had an injury related to like, I had like it was almost like a tendonitis sort of after a run, and it was like in my foot, and that was like 10 years ago. And I still, when I walk, have that pain. And it is something that is hard to, this chronic type pain is very hard to manage. And if you have a thing that helps with it, this deep massage, then the reason it probably comes back is because you are due for another deep massage and you found something that really works. So in terms of why pain becomes chronic is it's not a greatly understood thing. And it could be some amount of chronic inflammation, chronic swelling, like this sort of like issue that can happen chronically, or it can be that, you know, there's always going to be some level of just like possible nerve damage related to the injury, or whatever the cause was of the foot pain. I hope you have an idea of what caused the foot pain, but if you didn't, then I mean, it can also just be something that happens like over a lifetime of walking in a certain way, or, you know, all kinds of reasons.
All right, so next is a little conversation specifically about gabapentin dosing. So Joe has mentioned, you know, myself and my clients often will take much more than the, I think 300 milligrams once at night was something mentioned. Megan says I take 3,600 milligrams gabapentin daily, which is 1,200 3 times a day. And then we have a few more after that.
Yeah, that's a lot. That's a lot of gabapentin, and it's not to say that's wrong. If your doctor has decided that that's a good amount for you, then that is perfectly okay. I will say that is a lot of gabapentin from my perspective. Now, I am not your specific provider with an expert knowledge on you specifically as a patient, but I will say that if that amount you found that it does help you and it doesn't reduce your, like your ability to like wake up in the morning and have like good amount of energy throughout the day, then it's safe. And your doctor would know if it was not safe for you, like your kidney function and things like that, like, because there are always other things to be considering. But yeah, that it's a high dose, but if it is something that has helped you, then it is a safe dose.
Yeah, and to speak to that, we've got 2 Davids here. So David Scott has said, yeah, I was taking gabapentin, but it caused me to feel fuzzy and a little weird, so I stopped it. So I think that's maybe the trade-off is you can go up and up and up, but if it's causing problems that are impacting other aspects of your life, then it makes sense to make a change. Let's see, to walk down the medication thing, the other David is mentioning, so the David that says 300 milligrams gabapentin at night is also on Lyrica and Cymbalta. Not sure if you want to respond to that.
Yeah, I think that's great that you're on different types of medications for neuropathic pain. I'm happy to hear that there's potential interactions which can cause, like, they're all, especially Lyrica and gabapentin, both of those things together can cause more of that fatigue, that central nervous system depression, especially. So again, if somebody's watching you closely, if you're going to all of your doctor's appointments, at least every year or more often sometimes, but at the very least, if you're on medication like that and that combination of medications, then you should be going to your doctor's appointments every year. And I think that my response to that is that sounds like a great regimen for you. And I'm glad to see that somebody is using different types of medications to tackle in similar classes, but they're not all in the same class of medicines to tackle this specific type of pain. Because that's really ideally how it should be. It should be that you're starting low, you increase doses slowly, and then bring in other types of medications if side effects are too high. For example, just simply increasing gabapentin alone and then making somebody too tired, peeling it back is not the answer and then the end all be all. It should be you then start grabbing from different classes of medications that can help with this similar problem. So it sounds like this is a great regimen for you. I hope that your pain is controlled on this.
Okay, and then let's see, we've got 3 more. I'm going to go a little bit out of order just to kind of keep us in the same kind of topic. So we've got someone mentioning, okay, Gwendolyn has an update, but I'm going to put you at the end of our queue, Gwendolyn. So an anonymous person is saying, I had an allergy reaction to the following. So 1, Cymbalta made them nauseous. Lidocaine caused my throat to close in my doctor's office, and lisinopril, I stopped breathing, was placed on a ventilator, and ended up in the ICU for a week. So the question is, should we talk with the doctor about side effects before taking the medication?
Yeah, I think that any hopefully most doctors that are counseling you well will give you the risks and the benefits of any medication, because anybody that's taking something and putting it in their body should know that there are risks to it, but then should also be weighing that with the possible benefits. If somebody didn't warn you about the possible allergic reactions to medicines, then I think that that's it's kind of it in best practice, like anybody should be telling you that like an allergic reaction is possible. The lisinopril thing, that sounds very horrific, and I'm sorry that happened to you. That is not the first time I've heard that with lisinopril specifically. This is a phenomenon that is known and very rare. So I like it sounds like you got the care that you needed with probably being rushed to the hospital and everything. But again, any sort of time somebody is counseling you on starting a medication, risks, benefits, always have that conversation. And you can even, as a patient, and there's actually a slide in a few to discuss about like how you can approach these conversations with doctors about what are the risks and the benefits. Because we all know that there are risks of opioids. So if somebody's starting you on opioids to manage your pain, then having a conversation about all the risks that are associated with that, but then also knowing that there are benefits to it. That's the specific allergic reactions to like the lisinopril one. I want to like harp on a little bit more, just because the end result was so extreme. But like that specifically being something that is a risk, it's a very, very low risk, and I'm sorry that happened to you. Lidocaine, having some like throat swelling, that is more common than the lisinopril thing, and it's not safe, obviously, and you should never have lidocaine again. But that's kind of how you do find out that you have these allergies, and it's really kind of the only way to know. So it's a little bit scary, and you shouldn't be taking medications in general thinking that there are no side effects and no risks in general, because there always are.
Okay, so then let's see, I'll again kind of take us a little out of order, but Gwendolyn, the person who was talking about suicidal ideation, says, sorry, I meant Cymbalta, but I meant Lyrica is what caused suicidal ideation. I also took Cymbalta for a while prior to knee replacement, and it just didn't help that much, but had no bad side effects. So that's an update to that story. And then last two, and I don't know, Becca, if maybe after you finish these, you want to take a break, or if you want to keep going. So I'll put that option out there. But these last two are more kind of general overall questions. So Ellen says, I have both pain coming and going from stress and chronic pain from arthritis and chronic inflammation. So what do you recommend for this, except for stress management techniques?
Stress management techniques are huge. And then also the different types of physical therapy is really not something to just be ignored. Strengthening all of everything that you have, all of the structures around the site of the pain is very important. And it's like why I talked right off the bat about how chronic pain actually gets started by like not moving. And because everything weakens around that area, and then it's like not giving it the support it needs, and then it gets even worse. So physical therapy, helpful. And then also like the biofeedback, stress management, all of that, helpful in terms of medications and like arthritis specifically. Ibuprofen and Tylenol. I'm always going to say that those are good options if it's right for you. And then also if you don't want to take the risk of taking a pill, another good thing that is an option for people is it's an NSAID patch, or like a ibuprofen patch, and it can put medicine. There's like the lidocaine patches, like I talked about, for like more so for like neuropathy, but there is like an ibuprofen patch, and then you have to get a prescription for this. You can't just get it at the drugstore, but you can put that patch like on your knee, and it can put ibuprofen just into that direct area, so you don't have the risks of taking the medicine and like on a systemic level. So those things have all been proven to help chronic arthritis, and chronic arthritis is so huge, especially for older adults, and it's something that people are constantly trying to navigate and trying to manage.
All right, then another observation from the group, Anne has said meeting with a nutritionist for a diet evaluation could be a good option, since there's evidence certain foods or supplements can affect pain and inflammation. And then two things in the chat. One is, can a chiropractor help with back pain?
You're asking somebody a little bit biased, because I think a lot of people do find, like anecdotally, that chiropractors are helpful with back pain. But chiropractors are not recognized from the American Medical Association as providers that like the science of chiropractors is not supported. Most commonly, this is like a lot of times, like a chiropractor for most insurances will not cover it. But but insurance companies will cover things like, and that's not to say all insurance companies, but I'm talking globally, like on a general sense. But insurance companies will cover commonly things like acupuncture. There's more data to support acupuncture helping things like back pain than chiropractors. That's not to say that there are people that don't find them to be beneficial. So don't, if you have a really great chiropractor, please don't leave me like mean messages about how they really work, because I know that it does for some people, but I am talking like on a general sense. So physical therapy, personally, I'm going to recommend a physical therapist over a chiropractor, and you can get a referral from your general practitioner for a physical therapy referral. That's a pretty easy thing to do.
Okay, now there's more happening. So let's see, I'm trying to keep everybody in order. So kind of more questions about these like alternative or different therapies. So one is, are you seeing any research into earthing or grounding mats to manage pain? And then we have 2 or 3 other questions specifically about these other kind of treatments. And then we have one on inflammation. So earthing and grounding mats for pain management is first.
Okay, so I'm gonna group that into my complementary therapies, which is, let me just go back to this slide really quickly, and I'm going to address that question, which is medical procedures. So physical therapy, we've talked about physical therapy, medical procedures, nerve blocks are things that are options for people with chronic nerve pain. That's a huge deal and not something that's really ever taken lightly. So these kind of like big deal sort of medical procedures they're things that can be talked about in your doctor's office, but minimizing, like with like using radio waves, like to reduce like electrical currents of like those ectopic nerve firings that I'm talking about. There's things that can be talked about in your doctor's office about medical procedures related to pain, and specifically like the neuropathic pain, because it's a really difficult thing to manage. And then I'm going to go on to complementary therapies. Really, like the biofeedback thing it's huge. It's like relaxation, meditation. It's all about the way that you're processing the pain and how that signal gets sent back down your spinal cord into your peripheral nerves. It's huge, and not something to be just sort of like dismissive of, because it takes a lot of work. It's not as easy as like taking a pill, right? So and then also acupuncture, like this is something that has been proven to be helpful, but traditional practitioners of this of acupuncture believe that like it disrupts the energy flow of the body. But then there's like the Western idea of like how it helps, and Western doctors think that it stimulates nerves to get them to like naturally like fire appropriately and reduces pain that way. So it's sort of it's sort of unknown, and it's kind of a funny thing in medicine. There's some things that we don't fully understand, but we have evidence to support that it does help. So insurance will often approve acupuncture, and then this like grounding thing I don't know much about, so I'm gonna not do the thing where I just kind of start like trying to answer the question without really knowing. So
we have other ones that are kind of in this same vein.
all right, okay.
So Caitlin mentions that Kaiser will cover a chiropractic treatment, assuming it's prescribed by a primary doctor. So something
Okay.
to know.
Thank you, Caitlin.
So this next few are what about myofascial release, structural integration, or Rolfing? I don't know if any of those phrases have meaning for you.
No, I'm
Okay.
sorry. I'm sorry to the person posing the question.
So then other ones, so there's been 2 questions specifically about cannabis and CBD or medical marijuana tinctures. Throw that out there.
That's something I didn't add to this presentation formally, but it's a really great point, and something I'll add the next time I do this talk, which is there is evidence to support it. CBD and medical marijuana are helpful in, they're definitely helpful in pain. They're helpful in like chronic nausea. They're helpful in, it's helpful in definitely in several different types of like management of symptoms. But I will say that there's not enough evidence to support its use in like a global scale of a lot of different types of like exactly how it works and like how it can really improve pain, and then like all of the side effects that are possible with it, because it is because it's so new in being integrated into like our standard sort of like management of these symptoms. There's a lot more research that needs to be done, but I know that there's evidence to support it. Obviously, we have medical marijuana that's approved for people, so we know that there is a benefit.
Okay, so one more about kind of like a specific medication, and then a question, and then a comment, and then we'll see where we land. Okay.
I think, and then we'll take a break in a minute, and
Okay.
then I'll have like a couple slides about opioids and some cultural considerations. So I think we'll run out of time if I don't, maybe, can you grab like the most general of the questions in there?
Yeah, I mean, this is just a question about Voltaren for arthritic pain.
Yeah, it's a great option, and I'm not sure exactly how that one specifically works. So if maybe during our break, I can try to look up exactly the mechanism of action for that one.
Okay, last 2. And then there's a comment that maybe would be better in for the break. Okay. So the last 2, Cesar says, thank you for such great information. You mentioned an NSAID patch, specifically ibuprofen. Given that it's not systemic, why do you think that isn't prescribed more often?
I think and I just looked up that medicine, the Voltaren that you were describing, that's an NSAID patch. I just did it really quick over here, but so it's the same medicine that I was kind of talking about, the class of medicines. And thank you for the great question. I think because the data to support how helpful it is it's a little spotty. Like sometimes there's in terms of like how effective it is compared to a systemic therapy, it doesn't work as well generally. But it is something that should absolutely be explored for people that can't take a systemic pill of it. So, I think that kind of, focuses in on exactly why, like maybe not as good, but it shouldn't be ignored as an option.
Okay, so last 2, these are more general kind of comments. So Linda is sharing, I have chronic pain and many comorbidities, hypertension, type 2 diabetes, sleep apnea, and depression, to name a few. I just want to mention that one big treatment regimen that cannot be bought, but is an important modality, is sleep. Make sure you're getting enough sleep. And then last is Beulah is sharing that I listened to a foraging doctor yesterday, and she talked at length about natural in wilderness plants. And then more talking about people's personal experiences with chiropractic and all of that. So
Okay.
just
All right.
other
Sorry about the
options
chiropractor thing.
on managing. But yeah, so that's all that we have as far as specific questions posed to you. So did you want to take a break now?
Yeah, I think I want to just add a couple comments. Sorry about the chiropractor thing. I will, I'm sure a lot of people are probably feeling like they have had good experiences with chiropractors. So don't let me just tell you not to even try. Because I think one thing that I wanted you guys all to take away from this is like that there are options, there are things to try. And then, yeah, like good diet is very important. Having like a healthy weight is important. A healthy body weight is important, especially for arthritis. So the nutritionist or the dietitian helping you kind of make those like diet decisions is also very helpful. Also knowing that herbs and natural medicines, they're medicines too. So knowing how they affect you is very important. Just because it's all natural doesn't mean it doesn't, affect like other sort of like more Western medicines in similar ways of like your body and the way that your body processes it. So, okay, now let's take a quick break. And thank you for everyone's, I just want to say, we're going to come back in, let's say at 11:25. It's 11:18 right now. And thank you for everyone that's sharing and for all of the detailed questions and sharing people's experiences. And I'll see you guys in a few minutes.
And for those of you who are still with us, take about 5 minutes. I want to remind everyone, and I will put this in the chat also, when Ashley offers the online survey later, we would like everyone to fill this out. So when you see that online survey pop up on your screen, capture that and fill that out. Then within the next few days, when the slides are sent out, I will also send out the separate CEU survey for those who want continuing education units. The emailed CEUs will be available from IOA, and these are for RNs, LCSWs, MFTs, LEPs, LPCCs, attorneys, and licensed fiduciaries. It takes about 12 working days to get the CEs, which will be delivered digitally. And if anyone has questions about these, you'll be able to contact me, Catlin Morgan, at cmorgan@ioaging.org. And I'm about to put all this information in the chat function for you. Thank you. If somebody needs a particular kind of certification that's not listed there, after I send out the CEU survey, you'll have an opportunity there to reach back out to me and let me know what you need. We like to confine our CEUs to these, but if there's a particular certification that you don't see listed there, reach out to me, okay? And you'll have my email. And there I've posted the continuing education information in the chat feature. And just for a reminder, in case you stepped away, it's there, reminding everybody to fill out the online survey later, which Ashley will be offering. That's for everybody. And then within the next few days, I will be sending out the separate CEU survey for those who would like continuing education units. And those are for the entities that I have listed there. But if there's something special that you need, just reach out and let me know about that too, okay? You are more than welcome, Mohammed. Yes, and we do have that question kind of in the holding tank about the Voltaren topical processing. Thanks for mentioning that. In terms of proof that you attended this webinar, I will be sending out a group email to everyone who attended, and the emails will be visible, so that will be a proof for everyone that they attended this webinar. If you need the specific CE, the CE certificates or something else from me, please feel free to reach out. But the email itself, because the emails will be visible, will be proof that you attended this webinar, provided that you came in under your own email or registered so. Also, if you did enter the webinar under somebody else's email, please let me know about that as well, so that, and who you are, so that I may credit you with attendance. Sometimes people trade their emails back and forth and their links and so forth, so I do need to know that specifically. I see Rebecca's back, so we'll be getting started in just a minute, as soon as Ashley's back too. And again, I just want to remind everybody that I put the information about CEs, as well as directing everybody to take Ashley's survey at the end. And that's for everyone, not just for people who are seeking CEs. Okay, looks like we're back in business, so we'll get started again.
Becca, there's one, I guess, yes or no question. Oh, nope, two. Okay. before we jump in,
Okay.
one is, does Voltaren, the topical, does that get processed through the kidneys? And then one for PRP, platelet replacement therapy, and those are the first two before.
I don't know what PRP replacement therapy is. Oh, platelet rich plasma injections. Okay, I don't know. I can't comment on those. But in terms of whether or not topical NSAIDs get processed through the kidneys, the answer is at high levels, it does. So like the instructions will be like, don't put it on an open, if there's like a scratch or something, never put that medicine over that, because it's going to be absorbed at a higher rate. And then it will be processed more so through the kidneys. If it's going mostly through the skin directly to that area, it does get processed through the kidneys, and at just like such a small rate that it's safe generally. And I'm never going to make huge generalizations like that are specific for each person, but I will say I'll say that I'm generalizing, but this is not to say that it's appropriate for every single person. But generally speaking, it's at such small levels that it's safe for people that have kidney disease.
Okay, beautiful. And just folks, Yeah, if you have questions, you can put them in the question and answer or the chat. Question and answer might be slightly easier. That way you can know if we're seeing it and get that immediate response. But either way, we welcome your contribution, and you will see me pop up if folks have questions.
Ashley, thank you so much. You're so necessary to this, and thank you to everybody's questions. Okay, so I want to now talk about cultural considerations and racial inequities related to chronic pain in the United States. You know, the first thing I want to say is that when approaching pain in any patient, the first and most important thing to do for somebody, for a provider specifically, is to avoid cultural stereotyping. The hope is that any provider that's caring for somebody with chronic pain is going into caring for this person with an open mind, being authentic, being sensitive and caring, because really self-reported pain is the most reliable indicator for pain. You know, you cannot go through being able to identify somebody's real pain without completely listening to what they are reporting. But that's also not to say that self-reporting and how people report pain is not different based on cultural considerations. So this is something that's really important. You know, different cultures express pain in different ways. I'm not going to get into like all the specifics about every single sort of like culture and how they're different from like others, because this is very, very nuanced. I'm going to cite a few studies as I talk about this, but I think just in general, what I want everyone to know is that providers, when they're taking care of people of another culture, it's important for them to educate themselves on the culture of those that they're taking care of, but also educating themselves on their own culture and their own biases and how these things can affect how they're interpreting the expression of the patient's pain. Because pain is so subjective, as we all know. There's no real thermometer or like X-ray that's going to be able to really figure out exactly how much somebody's experiencing their pain. So I think what I want to get through on this study is that there are just some wide, obvious inequities in the way that people are managed with their pain. So I think what I want to get at too is like, this comes from somewhere. This comes from a history of racism and bias in the United States. So this is a study that's like cited very commonly now because it was so shocking. It was in 2016, so not even that long ago. A study examined 200 medical students, and they were asked about how they, you know, their perceptions on like Black patients and how they're expressing, how they are interpreting their pain. And it shocked the United States when 22% of I don't know the race of all of the 200 students. I think that information is available, but they thought, the people answering the questions, these medical students in 2016, 22% of them thought that Black patients had less nerve endings compared to white patients, so that they did not experience pain in the same way. And then that was really shocking to people. And then also in that study, which also gets referred to a lot, 63% of people of the medical students, 63% thought that Black patients had thicker skin compared to white patients. So these things sort of like were really shocking to the medical community about like where these sort of like these thoughts were kind of coming from, because it wasn't being taught in the medical books, but this is how people answered these. And these are medical students. So also a study found, this was a study in 2020, so it was just last year, found that Black children were given less, they were less likely to receive receive pain medication in the emergency room when they're being treated for appendicitis. So there's also a study in 2019 that showed this, and so all of that is to say that there's inequities in the way that that pain is being treated. Then I also wanted to just talk about like expression of pain and the way that pain is expressed like in different cultures. In 2019, a study showed that South Asian immigrants, and this was done by the United States and Canada together, showed that that these patients were more likely to express like physical related pain issues when associated with depression. So instead of coming in with symptoms like I'm so sad and I can't get out of bed, it more manifests as like a stomach ache or just like full body like aches and pains. So the expression of pain and also like the way pain's perceived is like really affected by culture. And so these are big things that I wanted to make sure that were talked about. And then generally speaking, Anglo-Americans compared to other ethnic groups in the United States are more likely to have their pain recognized and more likely to have analgesics and pain medicines prescribed to them. And I think the thing I want for everyone to take away from this slide is that the clinician's responsibility to really have an understanding of the different cultural groups and the biases that have kind of like helped build the system. So community health advocates and community education and things like that are just really, really important, especially for providers. Ashley, I see you unmuting.
Yeah, there's just, I think, a lot of echoing of what you're saying. So in the Q&A, someone says, thank you for bringing up this kind of cultural considerations, because it is really valid and really important to discuss. And then Gina has a perspective. I tried to tell this information to a former classmate who's a nurse, and she challenged me and said it wasn't true. And this speaks to the fear and distrust the African-American or her community has, I suppose mine too, has towards the medical community. And then another person says, I can relate. My son, who's African-American, tore a ligament in his ankle, and the doctor didn't prescribe a pain reliever, wrap, or give him crutches, just told him to take ibuprofen, and even that wasn't offered.
Yeah, that makes me sad because it's just really, I think something that is really real and pervasive, and medicine is no exception in this world that we live in, how sort of like backwards it is, and like how it was also built on the same system as everything else. So medicine's no exception, and all of these problems that are pervasive everywhere, like in every structure in the United States, it's not any different in medicine. So it's a shame, because obviously people's health and their physical well-being is like one of the most physical and mental well-being is like one of the most important things that we can be providing for people. So thank you for sharing that. And
David says, and this speaks to kind of the idea of cultural humility, right? Is that clinicians should ask their clients about their culture's attitude towards pain expression, right? Versus having this cultural competence, having a cultural humility and asking. And Anne says, we empower ourselves by becoming informed and learning to be stronger advocates.
Yes, absolutely. And I think that asking the question of the patient is very important. Asking cultural considerations and questions of the patient is very important. But then also just like self-educating and expecting our clinicians to self-educate too, because it is so much more on the clinician to have an understanding of these things versus a patient to have an understanding of their own culture. While we do, at a certain level, we all have sort of an understanding of our own culture. Some of it we don't necessarily totally understand because it's just our normal, right? And when you have to consider that in contrast to somebody else's normal, it's sort of hard sometimes to really like have a very specific explanation of. So it's really, really on the clinician to understand these things, but including the patient is important. Okay, now we're moving on to opioid use. This is a big, giant topic. And I think the big things I want to talk about is just like that non-pharmacologic therapy is very important. So it's like all the multimodal things that we talked about, physical therapy and biofeedback and all these things are really important because, and then using as many different types of medicines as you can in different classes is also important so that you're not just upping in the same class of medicine, especially something like opioids. So before starting opioid therapy for chronic pain, clinicians should establish treatment goals for the patients, setting realistic goals. Very important is that patients are not told or like they need to be educated on the fact that like maybe their pain is not going to be 100% taken away, and that is a sad fact that medicine alone and just even all the multimodal therapies, all that combined can also still leave people with chronic pain. So setting those realistic goals is important. Clinicians should only offer opioid therapy if it's clinically very meaningful to improvement, and also that risk benefit analysis has been done, really outweighing the risks of patient safety, because we know opioids are dangerous. And the CDC also reminds clinicians, these are like clinical rules, they're pearls for clinicians to use immediate release opioids. So if somebody's on like a long release acting opioid that lasts all day long, that is because that person's been on opioids for a long time. They've seen a pain specialist, like they're already deep in the system with all of these things. And like, you should never see somebody that just like goes from taking ibuprofen to like a long lasting opioid. And then they tell clinicians to start low, go slow, start at a very low dose, don't increase it to like start at like every 6 hours, start at 5 milligrams instead of like giving 10 milligrams every 3 hours right off the bat. And then also like big important things are like prescribers need to go through tons of hoops to be able to prescribe these medications. You have to have a DEA license that goes through the federal government. There are laws that say that if you're giving somebody opioids at a certain amount, and then especially rules if you're combining it with something like Lyrica or other medicines that are central nervous depressants, then you have to give like opioid reversing agent like Narcan. You have to give a prescription for that too. These are all rules from the CDC and the federal government because we have an opioid epidemic, as we all know. And then also when a clinician is prescribing medication, an opioid or like a controlled substance in general, they have to check this system online it's called CURES. It stands for Controlled Substance Utilization Review and Evaluation System. And that is for the state of California. It exists in all states. It's called different things in other states, but it's a way of tracking these controlled substances that are being provided to patients, so that if you are prescribing a controlled substance, it is on the clinician. You're breaking the law if you're a clinician and you're not checking this first. You have to make sure that the patient is not getting it from other places too. So that's just all to say that it's like a very, there's a lot of, it's a lot on the clinician and the prescriber to make sure that they're doing this responsibly, because there are risks to these medicines. So long-term opioid management treatment is often just like a very stressful thing for patients, for providers, and the reason is because we have this opioid epidemic, and the way it is an addictive medicine, and also it comes with some serious side effects. And the side effects are things like constipation. One thing I want to comment here before I go through all the side effects of opioids in general, is that this tolerance builds up to the medicine and the amount that you need. So like what people need becomes higher and higher to reach the same goal over time, but the side effects do not. So the more you need in terms of like pain management for your opioids, it does not mean that you need more to become like even more constipated or have other side effects too. Those side effects don't change. So you might need double the dose for your pain management, but all that means is that you need that much more for pain management, but you also you're receiving double the risk of like all the side effects too. So that's to say that like tolerance to constipation does not occur. The tolerance to the pain relief occurs, but not the constipation. So patients should always be on like Miralax, Senna, Colace. These are all really common ones. Then it goes like more aggressive, like milk of magnesia and other things that you can give to patients that are on high doses of opioids. But anytime somebody is on an opioid, for even if it's for a few days, they should be on something to reduce the risk of constipation, because constipation is a very serious side effect, not something to be overlooked. And then also nausea and vomiting, that is something that occurs with opioids. So medicines like Compazine, Ativan, Reglan, those are common ones that you'll see. I will say that Zofran is a medicine that you see a lot prescribed with it, but actually Zofran is constipating too. So whenever I do like medication reviews for our clinical collaborative members, I always kind of like will give that little, I'm just throwing it out there, Zofran's constipating. I mean, a lot of people don't know that, but that combined with, it's like back to what we talked about earlier, combining these medicines, knowing which side effects are adding up to be one big side effect and like increasing your risk of things. And then I'm going a little faster because I'm running out of time a little bit. I only have a couple more slides, but you know, respiratory depression, this is rare in opioid tolerant people, but it is to say that the tolerance of this side effect does not completely go away just because you're needing more and more medicines. But it is also something to be very, very observant of when patients are taking several different medicines that are increasing the risk of that respiratory depression and like the central nervous system depression, which is like benzodiazepines, like Ativan is one of those, and the combination of those things is risky for that respiratory depression. So for long-term pain, the benefit is unclear about exactly, you know, it's unclear because pain is a difficult thing to really measure in a meaningful, like sort of like quantitative way. But there was a study just last year out of Germany with 11,000 people that were enrolled, and it showed that people using long-lasting opioids for chronic pain versus other types of medicines, like, for example, like an SSRI, they were at a significant increased risk of death compared to the patients that were not taking those medicines. And it wasn't very specific on like what the cause of it was, but like, you know, one thing that we're watching for in a major sense is like this unintentional overdose. The CDC provides programs and like gives state governments tons of money and funding to be able to track these numbers. And that's why the CDC and the federal government also has all these requirements for providers that are prescribing these things, because they are helpful for pain and specific types of pain 100%, but they don't come without very serious side effects. And then I think that one thing I really wanted to make sure that I talked about was, you know, this opioid-induced hyperanalgesia effect, which happens when people are taking opioids for many years. There's this oversensitization of pain that can be caused by this this exposure to opioids. So what we find in the hospital is if somebody's taking opioids for many years, and then they are, if we cause pain, like by doing surgery or something, their pain levels are so much harder to control because of this phenomenon that's well documented. So it can actually make pain even harder to treat in the long term. And then I wanted to talk about tolerance versus dependence versus addiction, because this is an important thing to specify. It takes higher doses of the drug to achieve the same effect when a person is first using it. That's what tolerance is defined as, when you need more and more to achieve the same effect. Dependence is when you have a person that stops using the drug and then their body goes through like a withdrawal, or, you know, think of even withdrawal being as like a headache after you skip a cup of coffee in the morning. to go off this drug, people generally try to avoid these symptoms. So you have to like go very slowly off the medicine. That's dependence. But addiction is different, because just because somebody's dependent on a drug doesn't necessarily mean they're addicted. And if somebody's addicted to a medicine or an opioid specifically, it is when somebody cannot stop taking the drug, they cannot wean themselves off the drug despite negative consequences in their life from using the drug. And this is also called substance use disorder. So I'm going to stop there and just see if there are any questions. And then I have one, let me just make sure. Yeah, one last slide, and then we'll wrap it up.
Okay, yeah. Mostly, I think you mostly covered this. There's a 3-part question that asks, how do opiates make people feel? I feel like you've covered that. What causes drug abuse? I think you've spoken to tolerance, dependence, addiction. And then question is, has like doctor shopping, like what has been done to kind of address that?
Yeah, that cures system that I talked about to avoid that is one of the best tools. And it, when it was first developed, I don't know exactly when, but many years ago, at least, I mean, I'm not even going to say exactly when, but it was first developed like once we started like noticing this problem that was occurring. It is something that people just used sometimes. But what happened was providers were just like, oh, this is an extra step. It's like too hard to, and maybe there's all kinds of reasons, but people weren't using it. Providers weren't using it. So they had to make it a law then. You have to check this because patients are doctor shopping. They're getting the same prescription from many different doctors. And it's a very important thing to try to avoid to protect these patients. And so that's why they had to make it a law, even for providers to follow.
Yeah, so that's someone else has your link, because I was like, Rebecca Hunt says the training is very informative. Thank you.
Oh my gosh, I don't know how
but you're getting nothing but praise over here. And
okay.
That is also the end of the questions.
Okay, thank you. So now understanding sort of like time-based pacing and activity cycling, this is important in, how to manage chronic pain and like managing it with being able to kind of teach people to be active despite their pain, because it like that cycle, I go back to the cycle over and over again. But when you are like in pain and you just kind of are sitting around because the pain is too much for you to be able to like get up and go mow the lawn, then we teach people, okay, if mowing the lawn is too much for you, if it's too painful, then you have to do this in cycles. You can go out and mow the lawn for 10 minutes, and then you have to do it little by little, either throughout the day or throughout the but that's a big example. But it also is like important for people, like as simple as like getting up and sitting in a chair to read a book for people that are really debilitated. It's the same idea, pacing your active time with your rest time, how long it takes you to like safely do a task. Because what happens is sometimes people with chronic pain will just be like, okay, I have to get through this. I have to just get out there and mow the lawn. Or have to get up and like sit up in the chair and like have a proper breakfast. And then they're like exhausted throughout the rest of the day. And then you find that they're sitting longer and longer because they've completely exhausted themselves and put themselves in a lot of pain. So it's important to like schedule breaks and all of this. The mowing the lawn is a classic example that I use, but like I said, it can be on a much smaller scale. So doing a task as much as you can without causing an extreme flare-up, it is going to be important. And then you just like do the task a little longer, a little bit longer, and being able to pace yourself and take rest time is really important. So people actually are able to get a lot accomplished doing it this way, and it's something that doctors' offices will often tell people to do. So I want to just conclude this whole talk by like giving suggestions for what to get out, how to be able to get the most out of your doctor's appointment. So like if you are somebody that has chronic pain and you feel like it's not being addressed, or you have questions in general about it, being prepared for a visit is very important. So writing down your questions, prioritizing them, and writing out an agenda, things that you want to see addressed during that visit is really important, because what a doctor is taught to do actually during a visit is to create an agenda. Doctors are, because they know a doctor cannot get every problem identified and like addressed in a 15-minute or 30-minute visit. So what doctors are taught to do is go into a visit and say, these are the items that I'm going to talk about. So patients, I'm telling you, should be doing the same thing. Here are the things I want to make sure we talk about. Write it down before you go in there. And then also when you are providing information about your symptoms, about your pain, perhaps making sure it is complete, making sure it's distinct, because it's really easy to want to kind of like give every like sort of like experience and detail about your symptoms, but making sure you're getting like a sort of like general like summary of the things that are bothering you is going to be important, and making sure again you write that down so it doesn't get missed. And then also taking medicines as prescribed, and making sure that like who's on the visit or on the medicine team, like your nurse practitioner or physician assistant, your doctor, medical assistants. All of these people are important to kind of know like who is there providing your care, and then making sure that you are being like really honest about your experiences. Because what happens sometimes is patients go in and they're like, oh, I'm fine, doc. And this happens more commonly than you would think. And then when they leave, patients are actually like in more pain than they're really sharing. So making sure that you're really being honest about your experience too is going to be important. And then ask for information about like when to expect results. So ask, and then setting the standard, like somebody brought up like side effects, making sure making sure you're asking like, what are the possible side effects and how fast will this work? When will I see results? Because what happens sometimes is patients don't know that actually it takes months for certain medicines to start working, and then their expectations are not in line with like the reality of like what can be provided. So those are my suggestions about how to get the most out of your visit. And then the last slide is just options for questions, and we only have 7 minutes left. So we'll see what kind of questions you guys have, and thank you.
So far, there's only 2. And while I'm talking, if everyone wants to direct your attention to the chat, I am correcting my spelling and putting the link to our evaluation survey. But the 2 things that showed up in the Q&A, someone says, what is your opinion on, I don't know how to pronounce it, Zanza, maybe, alprazolam extended release. So the question is, do you get to a point of tolerance and need to increase the dosage on that? And then kind of follow up to that is, when should an individual start getting off of a medication?
Great questions. The medications that end in PAM, like the ending of that word generally is like a benzodiazepine. So that one you also can build up tolerances to and like need more of it to answer that question. And then in terms of like when to start weaning off of these medicines, this is a really personal answer and different for everybody about exactly what your goals are as a patient, and also in terms of like how much medicine you're needing and what side effects you're experiencing. So this is really different for everybody, but there are entire specialties of medicine that are designed to be able to help people wean off of opioids specifically. And there are entire clinics that are designed just for that. So if there is anybody out there that feels like they want to, there's a lot of help out there in order to do it.
Great. And then last 2 are just kind of recommendations in keeping with how to get the most out of your doctor's appointment. So Beulah shares that I have a medical notebook, which they started in 2003 when they were diagnosed with breast cancer. And then Allegra says, when I make or have a medical appointment, I email my doctor ahead of time to make sure they know my concerns beforehand.
It's a great, those are really awesome things to add. Thank you.
Yeah, so unless the rest of the audience has questions, I don't see any questions or chat that have not been addressed at this moment. So I want to direct everyone's attention to our Surveymonkey link. That's just the clinical collaborative survey that helps us see if this training was helpful and helps us kind of direct our research for the future.
Awesome.